Okay, what I was saying was the partial pressures, right, is going to be something really important. So 21% of our atmospheric air is oxygen. So oxygen is 21% of our air. So at 760 millimeters of mercury, which is the amount of pressure of the entire atmosphere at sea level, you're going to have about 159 or 160 millimeters of mercury that are due to oxygen. Okay, so at 37 degrees and a 100% humidity in our lungs, it's more like 150 millimeters of mercury. All right. So that's a little bit on Dalton's law. Again, don't worry too much about these laws, but I kind of want you to know a little bit about partial pressures because it's actually a really important concept, right? And then Boyle's law, right, basically says that, you know, that there's an inverse relationship between pressure and volume, which we already know, right? And then the ideal gas equation, don't worry about it again, but, you know, pressure and volume are basically you know, inversely related as well. But you also are going to have this universal constant R, right? And you're going to have temperature. So you're going to see that temperature is also going to be in the equation, which is why the pressure is going to change at 37 degrees of temperature. All right. So again, 21% is going to give us 760, right? And since we displaced about 24 millimeters of mercury due to water because we humidified it at 100% humidity, right? So it'd be about 155 millimeters of mercury. All right, so basically, again, what that tells you is that partial pressure of oxygen is 160 in the air and about 150 millimeters of mercury in your lung. Okay, carbon dioxide is only about 0.25 millimeters of mercury in the air, right? A very small percentage. Water vapor is going to be about 0 in the air and dry air, but in your moist 100% humidified air, it's going to be more like 47. Right? So the spirometer, okay, so going to something else, the spirometer, like I was explaining in lab, right, the spirometer basically works by as you breathe in and out, it's going to create this bell goes up and down in a column of water that is basically going to translate the milliliters of air that you might have into a displacement of this bell in water. As it goes up, right, because you're putting air into it, right, breathing out, you're going to see it going going down for expiration, and then as it goes up, it's going to mean inspiration. So inspiration is going up, expiration is going down, and that basically is going to displace by pretty much every tick mark, meaning a particular amount of volume. And so it basically tells us how much volume of air is in our lungs. And we have different volumes of air that we really want to worry about, like things like tidal volume, which is going to be normal respirations. Then we have what we call inspiratory reserve volume and expiratory reserve volume, which are going to be used when we're really straining to breathe, like when we're exercising or something of that nature, or hyperventilating, right? Inspiratory reserve volume, tidal volume, and expiratory reserve volume together make our vital capacity, right? So vital capacity, as you see here, vital capacity is going to be the amount of air in milliliters or liters in which we can move air in and out, right? The amount of volume in milliliters that we can move air in and out of our lungs. A residual volume we can never get rid of. That is the amount of air, well, not never, but very hard to get rid of, because that is the amount of air that basically keeps your lungs inflated. Okay. Your functional residual capacity, total lung capacity, inspiratory capacity, and vital capacity are all going to be calculated from your 4 volumes. Your 4 volumes are inspiratory reserve volume, which we abbreviate IRV, TV, which is tidal volume, expiratory reserve volume ERV, and residual volume RV. So notice total lung capacity is obviously going to be all four of them added together. Vital capacity is only the ones that are actually functional and where we can move in air in and out. So that's going to be IRV plus TV plus ERV. Functional residual capacity is actually a really good one because it is going to be ERV plus RV, because during normal breath, remember tidal volume is normal breathing, normal quiet breathing, this is the amount of air that actually stays in our lungs. And then inspiratory capacity is TV plus IRV, so how much we're able to breathe in. All right, so flow, again, is directly proportional to the change in pressure and inversely proportional to resistance. It's a really important concept to know, right? So respiration and the respiratory cycle is going to be one inspiration, one expiration, right? Now, you can see here the pleural space is the diaphragm at rest, right? In contraction, the diaphragm is going to flatten. When it flattens, your volume of your lungs actually in the space is actually going to become greater. So as the volume increases, pressure decreases, because remember they're inversely related, and air flows in. Remember, air flow is going to follow pressure. All right, in expiration, then you're going to relax the diaphragm. The diaphragm goes back to the this position in which it is dome shaped. The volume decreases, right? The pressure increases and air flows out. Right, so you can see here that your ribs are actually kind of pointed in a downward position. So in order for us to like a handle on a bucket, or like the handle here on a hand pump, you're going to increase, right, the position of your ribs, and that's actually going to create a greater volume. Okay, so see, like a bucket handle. And so by doing that, you're going to actually also cause air to flow inward. So which muscle does what? So your muscle is actually your diaphragm. By contracting, it's going to cause air to flow in, right? And then your rib cage is going to have two muscles, right? The external intercostals and internal intercostals. The external intercostals are going to help move the air in because they lift your rib cage, okay? So elevates your rib cage. Whereas your internal intercostals actually depress your rib cage. So they're actually going to help with forced expiration. All right, so you can see some of the pressure changes. So intrapleural pressure is actually going to be lower, right? Why? Because intrapleural pressure needs to keep your lung kind of attached to it. So the intrapleural pressure is always going to be lower than the pressure of your lung. If you were to get a gunshot or a knife through your lung, what's going to happen is that intrapleural pressure is actually going to go down. And when it goes down, then you are, I mean, it eliminates, right? It's no longer there. And so that negative, that lack of that negative pressure is actually going to cause your lungs to collapse, because the pressure inside your intrapleural space and the pressure of the atmosphere are going to become equilibrated. And when they do, then you can no longer keep your lungs inflated. So intrapleural pressure has to be kind of excluded from being exposed to the air so that it can always stay lower and keep your lungs inflated. All right, so you can see that the pleural fluid keeps the lung adhered to the chest wall, right? And so that lower intrapleural pressure actually also helps it keeps it inflated, right? But if you got a knife, right, a pneumothorax might result after a knife wound, right, where there's going to be air that's going to get into this, and then the lung's going to collapse. And remember, lung collapse is called atelectasis, right? So compliance and elasticity, right? So anything with high compliance is something that stretches easily. So your lungs are going to be quite pliable, right? Have high compliance, have a lot of elasticity. The older you get, the lower the elasticity, okay? So if your lung has low compliance or something that does not stretch very easily, like you might see in restrictive lung diseases. Remember, you have COPD, which is obstructive, which means there's something obstructing the flow of air. Restrictive lung diseases are something that restrict the lung from expanding, like sometimes like fibrosis, or inadequate surfactant production are going to be restrictive, that they prevent the lung from using all of its elasticity. All right. Yeah, don't worry about the law of Laplace, but see, the surfactant, again, don't worry about calculations, but don't forget that surfactant reduces surface tension, right? And so what that does is that it prevents, right? It prevents these from sticking together. Okay, so surface tension would be, you know, like like if water droplets get close to another water droplet, they come together into like one big droplet, and that's because they have a lot of surface tension. And I don't know if you've seen those little water striders that actually sit on the top of water, like they're like little bugs, like spiders, and they actually don't break the surface tension of water. Water has a lot of surface tension, so that's why we need surfactant, because the surfactant decreases that surface tension and it prevents anything from sticking together. Because I don't know if you've seen it, but water actually makes things stick together very well. You will notice that when you're trying to separate glass slides, they don't even have water because they're actually coated with something like a surfactant so that they don't stick together, and they still stick together. Don't worry, you'll see it more in micro. Right? So mixture, right, containing proteins and phospholipids. So it's kind of like a waxy, right? And you have that newborn respiratory distress syndrome in premature babies because they don't have enough surfactant. Okay. All right. So pulmonary ventilation, right? Total pulmonary ventilation is going to be the ventilation rate, right? Which is about 12 breaths per minute. 12 to 18 breaths per minute is normal. So anything lower than 12 would be a bradypnea. Anything higher than 18 might be a tachypnea. So a tachypnea would be definitely when somebody's hyperventilating. And then your ventilation rate, which is, let's say 12 breaths per minute is normal, and your tidal volume is about 500 milliliters, you're getting about 6,000 milliliters per minute in, okay? And then alveolar ventilation, your ventilation rate, but minus the dead space volume. So remember that only certain amount of air actually gets to the alveoli and to areas in which it can exchange what we call the respiratory division, where it can actually cause exchange of carbon dioxide and oxygen, where you can actually load oxygen onto the red blood cells. And so the rest of it is called dead space, right? So you can see here a little bit on which those areas that don't always exchange gas, right? It says because the conducting airways do not exchange gases, but they are known as anatomic dead space. Okay, so they are the anatomic dead space. Okay, so there you can see eupnea, hyperpnea, right? Hyperventilation, tachypnea, dyspnea, difficulty breathing, apnea. Okay, so these are some of the words that you want to know. Eupnea is being normal breathing. Remember, EU is normal. Right, so total pulmonary ventilation, total alveolar ventilation, right, takes into account that anatomic dead space, maximum voluntary ventilation, and respiratory rate, about 12 to 18 or 20 breaths per minute. Right, so hypoventilation is going to basically not have sufficient oxygen, right? So you're not going to have sufficient oxygen, and you're not going to get rid of sufficient carbon dioxide. So hypoventilation is bad. So the alveolar gases, you need to have a certain amount of ventilation in order for you to have the right amount of exchange or diffusion that can occur, right? With hyperventilation, notice that it starts to decrease because you're not going to be able to exchange gases if you're ventilating too quickly, if your respiratory rate is too high. Right, so you can see here, obviously low oxygenated blood, the alveoli is going to be where the oxygen is located, and the oxygen is then going to transfer itself by diffusion through the respiratory membrane. Okay, so you can see the bronchiole might be over here and the alveoli over here, and now it's oxygenated blood. That's called, right, this is the movement of blood through this area. It's called perfusion, right? The movement of air into the alveoli is called ventilation. Okay, so ventilation and perfusion are very important. We do not want a ventilation-perfusion mismatch, right? If you're underventilating a particular area, so for example, this area here is underventilated, then what you're going to have is you're going to have an increase in carbon dioxide and a decrease in oxygen, the partial pressure of oxygen. So if the partial pressure of oxygen is lower, then why are we going to send blood in this direction? So basically what we'll do is we'll use a little precapillary sphincter that'll kind of block off the ventilation to this area that's getting poor. Why are we going to perfuse this area if the ventilation is poor? Right, so you're going to see that local control is going to see how that blood vessel is going to narrow. And then so the